So BCLC staging based on tumor burden, liver function and physical status. They have classified this into 5 stages, that is stage 0, A, B, C and D. Stage 0, also called as very early stage, where the tumor is single and with less than or equal to 2 centimeters with good liver function and good PS. So in all, we see the size, function and PS. Just like as AFP, it is SFP, size, function and PS, performance status. So if the tumor size is less than or equal to 2 centimeters, then these patients are potential and they are potential candidates for liver transplantation. That means these patients can tolerate surgery. It's not just liver transplantation, you can still go ahead with just resection. So, and these patients are candidate for liver transplantation. Yes, then you should with normal portal pressure and bilirubin, then you should consider for resection. But if these patients are not candidates for surgery, then you can go ahead with ablation. Coming to early stage, which is here the size is less than or equal to 3 centimeters with less than or equal to 3 nodules. Again, with a good performance status, or if it is single with less than 3 centimeters, less than or equal to 3 centimeters. In these patients also, if the tumor is single, then you should with normal portal pressure and bilirubin, then consider for resection. If portal pressure and bilirubin are increased, then you should consider it is a contraindication for surgery, and then we should consider for ablation. Or if the tumor is less than or equal to 3 nodules, each less than or equal to 3 centimeters, and there are no contraindications for liver transplant, these patients are ideal candidates for transplant. Basically, if it is multinodular, then you should consider for transplant. If it is single, size less than or equal to 3 centimeters, consider for resection. There are criteria for extended resection also. Coming to intermediate stage, again if it is multinodular, more than or equal to 3 nodules, it is considered as multinodular with preserved liver function and good PS. These patients are candidates for extended liver transplant, then you can consider for transplant. If these patients are not candidates for extended liver transplant, then again these patients with well-defined nodules with preserved portal flow and selective access, and these patients can be considered for transarterial chemoembolization. But whereas patients with diffuse extensive bilobar involvement and not good candidates for TACE, and or if the patient does not have a preserved portal flow or selective access, then you should consider these patients for systemic treatment. Their expected survival is more than 2 years when you start them on chemotherapy. That is, first line chemotherapy is atezolizumab with bevacizumab or durvalumab. If it is not feasible, then you should consider giving them sorafenib or lenvatinib or durvalumab. In second line post sorafenib, you go ahead with the second line treatment with regorafenib or cabozantinib or ramucirumab if AFP is more than or equal to 400 nanograms per ml. And if these patients have portal invasion or extra-hepatic spread, that is nodal involvement with preserved function, PS, good PS, then you consider for systemic treatment. But whereas in end-stage liver function and with any tumor burden, if it is already LFT or deranged with poor PS, then you should consider these patients who are as terminal stage and only offer best supportive care. So main things that we need to remember here is that all patients you have to evaluate portal pressure and bilirubin also. If these two are deranged, then they're out of the resection or transplant category. You have to consider them as terminal stage D. Radioembolization can be considered if there is single lesion which is less than or equal to 8 centimeters. And resection can be considered in any patient with single peripheral HCC and they have a good remnant liver volume.